Well, thank you, Stanley, and thank you, Steve, for the invitation. The slice I'm going to talk about today has to do with neuroimaging and Alzheimer's disease. So you probably know that Alzheimer's disease is the greatest fear of older people. The idea that you would lose your cognitive capacity and your ability to know oneself is a scary thought. The disease is increasing at a rapid rate as the population ages, has huge public health consequences and huge economic consequences. The cost of Alzheimer's disease is estimated to be over $2 billion. This doesn't do anything. It's estimated to be over $2 billion in the costs of care, nursing home care, caregivers' loss of time, and the overall impact of the disease. Unfortunately, there's no cure for Alzheimer's disease, and the efforts at drug discovery have been rather sad. And if we think about what the causes of that are, there are many of them, but one of them is that as people have attempted to deal with drug discovery, originally they looked at people who had Alzheimer's disease and looked for pharmaceuticals that would address the disease in living people. It turns out that that's not at all effective. As you move back in the disease process, 2 decades before the disease is apparent, there are already changes in the brain. And so as you think about drug discovery, then you start thinking about people with mild cognitive impairment, and then cognitively normal people who will go on to get the disease. So then we start thinking about biomarkers. What are the biomarkers in the population that suggest who's going to get the disease? We know a few of them. Age is one of them, obviously. One of them is the ApoE4 allele. The apolipoprotein E has 3 alleles, 2, 3, and 4. 2 is a little bit protective. If you have one E4 allele, you have a 30% chance of getting Alzheimer's disease. So if you look at the person on the left and the person on the right, if each of you had one E4 allele, one of you will get Alzheimer's disease. If you're unlucky enough to have 2 alleles, you have a 90% chance of getting the disease. But you can see that doesn't totally predict what's going to happen. So the search is on to find biomarkers that will predict who will later, some 20 or 30 years hence, develop the disease, so pharmaceuticals can be directed at people before the degenerative process. So there are some that we know about. Amyloid in the brain is one of them. And the structure of the brain is particularly the structure and the size, the volume of the hippocampus. But they too don't totally predict things. It turns out that in order to predict the disease, we're going to need probably a group of biomarkers that together are the most predictive. And that's where olfaction comes in. If you look at the brain in a normal person, all of you look like that. In the very first stages of Alzheimer's disease, in this area here, the entorhinal cortex, appear the first tangles. Rhino means nose, right? It's an area that processes olfactory information. Incoming information from the olfactory bulb synapses once in the entorhinal cortex and then goes on directly to the hippocampus. So you can see that if you disconnect that incoming olfactory information from everything you've ever known about that odor, remembered it, named it, whatever, you should be reflecting the disease in olfactory performance. And so that's in fact what we and others have looked at. And in Alzheimer's patients themselves, odor threshold, odor memory, odor identification are all impaired. And odor identification has really a robust finding. So now we step back in time and we say, well, what about people who are at risk for Alzheimer's disease? Can you see it already in those who are at risk? And in fact, if you look at people with a family history, people with this ApoE4 allele, and people who have mild cognitive impairment, you're starting to see these olfactory dysfunctions. And so all of that would predict it might in fact turn out to be a reasonable biomarker if we knew more about the mechanisms that underlie this biomarker. So that's what we've been focusing on. We've used neuropsychological assessment, functional MRI, and event-related potentials to address a series of questions that you see here. And they all focus on this holy grail of finding who in the population is going to get Alzheimer's disease. So the last question, does it help to be thin? Obesity has become a global epidemic, and we know it's associated with diseases that are really important, but to me what's important is it's associated with cognitive impairment in later life. If you're obese in middle age, if you have diabetes or even insulin resistance, you have a much greater likelihood of developing cognitive impairment. And if you die with Alzheimer's disease and you are obese, you'll have a much smaller hippocampus than if you're not obese. So it appears to be very important in the development of the disease. So we've investigated with fMRI, and we've particularly looked at olfactory function in people who are of varying levels of BMI. Now, one thing about the brain when it's thinking about taste and odor, it's very dynamic. It responds more under certain circumstances. So this is the brain's response to sweet in red, bitter in blue, and yellow is sour when people are sated. So you've had big snacks over here, you should be sated, brain should look like this. If you were very hungry, your brain would look like that. So the brain is much more reactive to sucrose when it's hungry. So we presented stimuli to people lying in the scanner who were hungry. And their job was to rate the pleasantness of that stimulus with a joystick by putting a mark here. The stimuli are all presented through a series of pumps and things into the mouth, and the subject is then lying on his back and he's tasting, quote, a stimulus. The stimulus is citral, which is an odor presented in the mouth, and that odor tastes like lemonade. When you think about it, 3 times a day you experience olfaction as odor in the mouth, retronasally appreciated by the olfactory system. Most of your olfaction is really retronasal. So to mimic real life, we put the odor in the mouth. And we looked at activation in entorhinal cortex, this critical place for the early development of Alzheimer's disease. What we found was that as BMI increased, the activation increased in entorhinal cortex. We did another experiment with people who have metabolic disease. So metabolic disease involves obesity, but also other factors that are highly related. So elevated triglycerides, elevated blood pressure, fasting glucose. So a constellation of things that separate people into 2 groups. And we looked at young, middle, and old people. And what we found was that not only do we have these activation differences in the brain, we found structural differences. We found structural differences already in that middle-aged group. So people who cognitively normal but have metabolic disease showed thinner entorhinal cortex as a function of risk factor burden for metabolic disease. And entorhinal cortex thickness also predicted total recall on a neuropsychological test. So there seems to be a relationship between metabolic disease, the structure of the entorhinal cortex, and memory in middle-aged people. So we have a working model that increased food intake and increased BMI results in increased activation in mesial temporal lobe areas, and particularly entorhinal cortex, that then results in degenerative changes, including thinner entorhinal cortex, a smaller hippocampus, smaller piriform cortex, that, happening over a lifespan in old age is going to result in a decreased fMRI response and this loss of odor memory and odor identification that seems to be this biomarker. This is our working hypothesis, and we're testing various pieces of it in our lab right now. So what have we learned? We know that olfactory function is profoundly affected in Alzheimer's disease, and it's also affected in people who have a genetic risk factor. We know that lifestyle variables like obesity impact olfactory response. That's a modifiable risk factor. That's a good thing. But we have a whole series of critical questions that all of this leads us to, and they focus on finding the earliest evidence of olfactory dysfunction using whatever means we possibly can. Event-related potentials, functional MRI, structural MRI, diffusion tensor imaging, in order to determine what tasks and what measures will at the earliest point predict dysfunction later. And so we're using multimodal imaging to do that. And our conclusion is that we believe that olfactory function will in fact be a biomarker that together with other biomarkers will help us to predict who's going to develop the disease. And may also give some clues as to potential targets for intervention. So acknowledge lots of money and lots of people, the many contributors, the San Diego State University Lifespan Human Senses Laboratory, supported by the Foundation, and special thanks to our fMRI team. And there we go. Thank you.
Terry, the beta amyloid, different forms, 40, 42, 44, those ratio has been quite reliable. And have you seen correlation between that and olfactory?
Thank you for asking that question. So last Friday, we submitted a grant through the foundation that involves Doug Glasgow at UCSD's Alzheimer's Disease Research Center. So he's the director of the center, but he's also a neurologist whose focus has been beta amyloid, A-beta 42, in the CSF.
Right.
And so he has a population of 120 people who are amyloid positive but cognitively normal. And we will be following those people over time, if we get this grant, and we will be studying their olfactory function. We'll be using fMRI, structural MRI, and DTI. And we're particularly interested in that population because they're cognitively normal, but they have this marker.
Exactly.
And I think that's going to be really interesting.
Let me try a crazy question. So you're treating the what you're seeing in the brain as correlative. What if it's causative? And you would test that if you knew what the effects were of depriving an animal from any scent. Has that kind of work ever gone on? Do you know what happens to the brain of an animal who's never allowed to smell anything?
Yeah, that's a really good question. And it has been addressed some long time ago in rabbits by closing off the nostrils and then looking at the development of the olfactory bulbs. And in fact, you get a smaller bulb on the side that is occluded if you occlude only one side. And it may well be that people who have nasal function disease, so polyps in the nose, nasal sinus disease, those kinds of things early in life, and then have olfactory dysfunction as a result of that, may well have some effect on their structures as a result of that. If we look at the population studies that have been done in olfaction, older people have less olfactory function than younger people, and some of that may be related to the kind of thing you're proposing. It's a very good observation.
So is there any specificity in terms of the kinds of odors that are lost, or is it totally generic? So my question is, if I stop to smell the roses and I can't, am I in trouble?
Well, there is a researcher in England named Christopher Hawkes who would endorse your thing, and he would say that cinnamon and another odor, I can't remember, I think it's peanut butter, that those two are the best odors to determine this. But most people believe that it's not specific to a particular odor. If you look at olfactory receptors respond to different odors, and in fact, as people get older, olfactory receptors respond to more odors, so they lose discrimination among odors. So it's likely if you're not smelling the roses, you're not smelling the peanut butter, the cinnamon, or the chocolate either.
So related to that, there was recently a report, and I looked up the article by this researcher, and they were suggesting that, and I don't know how well documented it was because I didn't read the whole thing, but that one way to sort of determine if people might have Alzheimer's was to actually present them with a small little cup of peanut butter, and they were to smell with one nostril at a time, and if there was a disparity between how much or what they smelled with different nostrils, that might be an indicator. And I'm wondering what the neurobiology is behind that, if you could comment on that.
Well, yes. In fact, I know those people. Jennifer Stamps was the graduate student who was the first author of that paper. And her advisor, Linda Bartoshuk, was my postdoctoral advisor, so I knew as they were developing that. And their test, which is to present a peanut butter odor as you gradually get closer to the nose, was based on the detection test that Terry Davidson, an ENT physician at UCSD, and I had developed using an alcohol swab, which we thought was a good way to test odor in any doctor's office because everybody's got alcohol swabs, right? So it's a quick screening test. It's not, highly, highly accurate, but it might suggest who should go and be tested. So they use peanut butter, and it's not as clean and neat as it should be. And so they were almost immediately smacked by Doty, who has this 40-item odor identification test, and said that it wasn't an adequate test. But the idea that you would screen people, a large population, and then those who don't do well, have them tested in a really precise way, that's a good idea. Yeah.
Time's up.
Thank you, Clive.